In this disease, there is escape of air within the pleural space and later push of mediastinum to opposite side. So what is this disease where there is air in the pleural space? It is pneumothorax. Let us see the classification of pneumothorax. Pneumothorax is generally classified into spontaneous pneumothorax and other is traumatic pneumothorax. Again, under spontaneous pneumothorax, we have primary spontaneous pneumothorax, then secondary spontaneous pneumothorax. Under traumatic, trauma happening in hospitals referred to as iatrogenic. Trauma happening outside, it is direct chest injury. So where does direct chest injury generally happens? As a part of road traffic accidents. So generally this direct chest injuries are dealt by surgeons. So today we will see non-surgical causes predominantly. This primary spontaneous pneumothorax, there is no pre-existing lung disease, but still pneumothorax happens. Exact mechanisms are not clear. Whereas secondary spontaneous, there will be a particular pre-existing lung disease, and that lung disease is responsible for pneumothorax. And what will be the most common lung disease in clinical practice responsible for pneumothorax? In which lung disease? There are hyperinflated areas called as bullas, which can break at any point of time, resulting air escaping to pleural space. It is COPD emphysema. So in COPD emphysema, there are hyperinflated areas called as bullas, so which can break at any point of time, resulting in pneumothorax. Apart from that, tuberculosis. Cavities can rupture, resulting in air escape into pleural space. Why it happens in ILD? When I discuss ILD, I will let you know in detail. Then rare diseases such as LCH and also LAM. What is this LCH LAM? I will discuss in detail in the next slide. Now coming to iatrogenic causes. What is the most common hospital procedure responsible for pneumothorax? I told you previously. I asked my first year postgraduate to get some sample from the pleural space. Gossiping with the intern girl, he inserted the needle very deep, not only damaging the pleura but also the lung. Whenever lung is damaged, air escapes into pleural cavity. So this common bedside procedure is thoracentesis, and it can also happen as a part of invasive mechanical ventilation. You know that this is a positive pressure ventilation given directly into the lung through an endotracheal tube. Whenever you give excess pressure to your alveoli, alveoli will rupture. Whenever alveoli ruptures, air escapes into pleural cavity, causing pneumothorax. And third important reason is insertion of central venous catheter. Insertion of central venous catheter, especially subclavian catheter. Subclavian catheter. You must be knowing, students, whenever your peripheral veins are not accessible, you go for central venous cannulation. One important is jugular and other is subclavian. So if you want to puncture the subclavian, you have to puncture beneath the clavicle. So when you puncture beneath the clavicle, accidentally lung apex might be damaged. So when you puncture beneath the clavicle, accidentally lung apex might be damaged. So these are the various classification of pneumothorax. Now these two diseases, LCH, LAM, Langerhans cell histiocytosis, lymphangioleiomyomatosis. Even though they are very rare in clinical practice, both of them have a special clinical presentation which will attract the examiner to frame multiple questions. With help of a table, let us see the differences. Rare diseases causing pneumothorax. On one side I am going to discuss LCH. On the other side we will discuss LAM, lymphangioleiomyomatosis. Now coming to LCH, this is due to abnormal accumulation of immune cells called as Langerhans cells. Langerhans cells in various parts of the body, such as your lung. It will accumulate in the bone. It will accumulate in the skin. Within the skin, the manifestations are vesicles, rash. Within the bone, one can notice osteolytic lesions. And in the lung, these cells will damage the airway. Once they accumulate in the airway, they can damage the airway and can be responsible for abnormal air-filled areas. This abnormal air-filled area is called as a cyst. Coming to the clinical presentation, this is a disease where smoking is the primary risk factor. So if you notice in the question, smokers with cyst on CT scan, and there is pneumothorax. So why there is pneumothorax? This is cyst is an abnormal air-filled area. Any abnormal air-filled area is very unstable. It can break at any point of time, resulting in air escape into pleural space. Now this disease is more of bilateral upper zone predominant. Initially one can notice solid areas called as nodules. Later there can be cyst formation. Treatment, mostly it is smoking cessation. Smoking cessation, and because these are all abnormal immune cells, you might need to give, to bring down their activity, steroid. So in extensive disease, sometimes even we give additional immunosuppression with chemotherapy such as cladribine, but in majority it is mainly smoking cessation. So stop smoking, then you have to give steroids. Coming to lymphangioleiomyomatosis. So there is myo in the name, and it is proliferating along lymphatics and vasculature. So this is abnormal proliferation of atypical smooth muscle cells. Atypical smooth muscle cells along lymphatics and vasculature of your respiratory system primarily, and also within the abdomen. These cells will accumulate on the kidney and they form a growth which is pathologically referred to as angiomyolipoma. Now what precisely happens in the respiratory system, especially in the lung? These cells can proliferate along the airways. They can cause damage to airways. Because of airway involvement, there will also be formation of cyst here. There will also be formation of cyst. Now these atypical smooth muscle cells can proliferate along the pleural lymphatics. That will result in rupture of pleural lymphatics. So once the pleural lymphatics are getting ruptured, students, lymph will start accumulating in the pleural space. What is lymph ultimately called as? Chyle. So it is also referred to as chylothorax. So if you observe here, students, in lymphangioliomyomatosis, along the airways, these atypical smooth muscles will proliferate. Once they proliferate, they don't keep quiet. They will be destroying the structures. Because the airway is damaged, there can be abnormal air-filled area called as cyst. And they can also proliferate along the pleural lymphatics, resulting in damage of lymphatics and accumulation of lymph within the pleural space. What is lymph ultimately? It is nothing but chyle. So this entity was also referred to as chylothorax. This entity was also referred to as chylothorax. Now the clinical presentation, here it is a disease seen in females. So women of reproductive age. Women of reproductive age, and if you have a cyst in the lung and presenting with recurrent pneumothorax, this will be the history. So young female or women of reproductive age, CT showing cyst and patient is having recurrent pneumothorax. Whereas on the CT scan, this is more aggressive disease, bilateral diffuse cyst, top to bottom, side to side, everywhere you can see plenty of cysts. Now coming to the treatment, recent studies have shown that this abnormal proliferation was due to activation of a protein called as mTOR protein. Activation of a protein called as mTOR protein. So now the treatment is mTOR inhibitor. The treatment is mTOR inhibitor. So what is the mTOR inhibitor available in the market approved for this disease? It is sirolimus. So treatment here is mTOR inhibitor and it is called as sirolimus. So studies have shown that why there is so much of proliferation, it is activation of mTOR protein, and the treatment is mTOR inhibitor sirolimus. Now let it be any of these two diseases. If patient is not improving with medical management, only option left is lung transplant. So medical management, if patient is not improving, he might require a lung transplant. So let it be any of these two diseases, the ultimate treatment, if patient is not improving, will be lung transplant. So once again, in the question, if you notice, a smoker, cyst, pneumothorax, think of LCH. Whereas in the question, if you notice, women of reproductive age, cyst, pneumothorax, think of LAM. So now you should know how will a cyst appear radiologically. So it is very difficult to identify a cyst on a chest X-ray. We have seen previously other air-filled areas, cavity, pneumatocyl. Now I'll show you three images. Let me compare and you will only know what is cyst, what is cavity, what is pneumatocyl. So three images. So this is image A, image B, image C. So just see these images and try to predict first of all what is cyst. Image A is actually cyst. So cyst, there will be air-filled area, and around that you can also see well-defined wall, but the dimensions of the wall will be less when compared to cavity. So cyst is a rounded area of air with well-defined wall, and generally the dimensions will be very less when compared to cavity. Whereas cavity is also air-filled area, but the wall dimensions will be more than 1 to 2 mm. And always know that cavity is associated with ongoing etiology. So cyst can be a primary pathology, whereas cavity is always a resultant of some ongoing pathology. So there can be previously in this area consolidation. Now it has cavitated, or there can be some mass. It can later cavitate. So here also you can see surrounding this there is some consolidation. Then what is meant by nematocele? This is an air-filled area and there is no proper wall. So you can see wall only up to here. This everything is not proper wall, and it is usually associated with some ongoing pneumonia, acute pneumonia especially. So here we have seen cyst, which is an air-filled area, well-defined wall, but when compared to cavity the dimensions are less. Cyst is generally a primary pathology, whereas cavity, it is a well-defined wall, more dimensions, and it happens due to some ongoing pathology. Whereas this nematocele, air-filled area, no proper wall, generally associated with some acute pneumonia. And if they give you any image of LCH and LAM, see these students, LCH is more of upper zone disease, whereas LAM is more of bilateral diffuse. And mainly you focus on clinical history. For LCH, what should be the important clinical history? Smoker, cyst pneumothorax. Female cyst pneumothorax, then it will be LAM. Coming to most important pathological form of pneumothorax, referred to as tension pneumothorax. Tension pneumothorax. Now for development of tension pneumothorax, there will be presence of large air leak. There will be presence of large air leak, and this air leak can function as one-way valve, or also referred to as ball valve. Let us see what is happening in tension pneumothorax. So consider this is your healthy lung, and let this be the diseased lung. Now because of this disease, air is continuously leaking into the pleural space, resulting in pneumothorax. Now nobody knows the precise mechanism behind tension pneumothorax properly. So they thought that the reason for such a sudden presentation was this air leak functioning like a one-way valve mechanism. So what is meant by one-way valve mechanism? During inspiration, all the air will go into pleural space. During expiration, nothing will come out, because nothing is coming out. See here, it is going into the pleura, but nothing is coming out. With each expiration, see, during inspiration, air is going in. During expiration, through that leak, nothing is coming out. So with each respiration, there will be increased positive intrapleural pressure. So there will be increased positive intrapleural pressure. Because of this increased positive intrapleural pressure, there will be increased compression of adjacent lung and mediastinal vessels. So once the great vessels are getting compressed, there will be reduction in venous return. Now once venous return is reduced, it will translate as reduced cardiac output. Because of reduction of cardiac output, patient will develop hypotension and he can land up in shock. Now why is this entity called as tension pneumothorax? Not because patient is in hypotension and doctor is getting tension what to do. See why all this is happening? Because of increased buildup of pressure within the pleural space. Pressure is also called as tension. So this phenomena is due to excess pressure in the pleural space. Pressure is also called as tension. So it was called as tension pneumothorax. Now because patient is presenting with hypotension and shock, this is an medical emergency. And mostly a clinical diagnosis. So no need to do any special investigation to prove it as tension pneumothorax. If you feel that is sufficient. So what are the clinical points suggestive of tension pneumothorax? Patient will have acute presentation, acute shortness of breath. If you put your stent, there will be absent breath sounds, and patient, if you percuss, there will be hyper-resonant note. If you percuss, there will be hyper-resonant note, and patient will be in hypotension. If you see this in combination, acute shortness of breath, absent breath sounds, hyper-resonant note on percussion, and hypotension. When you see this in combination, your suspicion should be tension pneumothorax. Now in this situation, what will be the next step or best step? Next step or best step is saving the life of the patient. How will you save the life of the patient? By insertion of wide bore needle. By insertion of wide bore needle, followed by ICD insertion on affected side. Now what is the benefit of this wide bore needle insertion? So once you insert the needle, it is going to decompress the cavity, relieve the pressure, reduce the compression. So once the compression is reduced, circulation will improve, patient will survive. But this single needle cannot drain whole air. For better drainage, you have to put an intercostal drain. Now few smart students will be asking me this question, sir, ultimately you are putting an ICD, what is the fun in putting needle first and ICD later? It is simple common sense. If you want to put an needle, it will just take 5 seconds. But if you want to put an ICD, it is a minor surgery. Even in experienced hands, it will take 5 to 8 minutes. In that 5 to 8 minutes, patient is not going to survive because of this tension pneumothorax. So needle is for immediate life-saving phenomena, or needle is for immediate life-saving procedure. Whereas later, in a relaxed manner, you can put ICD and you can make the patient experience all your surgical skills. And especially in few hospitals, if you ask for ICD, it will come after 1 or 2 hours. Meanwhile, patient may not survive. So immediate life-saving procedure is needle. Later, definitive will be ICD insertion. So the next question, what is ideal site of needle insertion and what will be the site of ICD insertion? Now for ICD, it has been always a single option. 5th intercostal space near mid-axillary line. 5th intercostal space near mid-axillary line. For needle, in the emergency department, to avoid confusion, nowadays let it be needle or ICD, they have made it uniform. 5th intercostal space, mid-axillary line. But for needle, there is also another option. So this is the old guideline. 2nd intercostal space, mid-clavicular line. See, why was this changed? So in emergency department, to avoid confusion, different place for needle, different place for ICD. See, somewhere you have to put. So what they have done, to avoid that confusion, these surgeons, they cannot remember too much. So what they have done, let it be ICD or needle. Now they have given a single option, that is 5th intercostal space, mid-axillary line. But for needle, you can also follow the old guidelines, 2nd intercostal space, mid-clavicular line. This is regarding very important phenomena, tension pneumothorax. So it is a medical emergency and clinical diagnosis. Next step or next best step will always be saving the life of the patient. And this pneumothorax is an examiner's favorite topic. Multiple questions have been asked recently. So let us see a case 16. A 64-year-old male who is requiring endotracheal intubation and mechanical ventilation for COPD. So this patient is having a dangerous combination, COPD with invasive mechanical ventilation. Again, there is something bad suddenly happening. Acute presentation. Patient's BP has fallen down. He is in hypotension and breath sounds absent on the right side. Absent breath sounds on the right. So what is the next course of action or best course? If you see this in combination, what are you dealing with? You are dealing with right-sided tension pneumothorax. So this patient, because of mechanical ventilation, he has developed tension pneumothorax. If it is tension pneumothorax, next step or best step is always saving the life of the patient. So first put a needle and save the life of the patient. All other things, fluid, ventilator management are next. Next step or best step is always saving the life of the patient. Next again, examiner's favorite question. I told you pneumothorax. So this patient was having a car accident. There is trauma history and dyspnea, chest pain, anterior chest wall bruit, peripheral pulses present, and on percussion there is tympanic note. Tympanic note, and also the breath sounds have been decreased on left. So when you see reduced breath sounds on tympanic note, these two situations generally indicate one condition, pneumothorax, and it may be due to trauma. So whenever I say pneumothorax, few students ask me, because there is trauma, no sir, why can't it be hemothorax? You only tell me why it is not hemothorax, students. Very simple. Hem means blood. Blood is also a fluid. Fluid will not give tympanic note. It will give stony dull note. And why can't it be collapse? Collapse again will give a dull note. Why can't it be cardiac tamponade? Cardiac tamponade has nothing to do with tympanic note. So that's why when there is tympanic note and reduced breath sounds, it is generally a single situation, and that situation is pneumothorax. Once again, this pneumothorax, many times either they ask you the chest x-ray of pneumothorax, or they will give you a clinical scenario suggesting tension pneumothorax. They'll ask you what is next step or best step.